So our speaker, Dr. Eric Matheson, is an assistant professor of philosophy at the University of Toronto, Scarborough. He also does ethics, consulting for hospital systems, non-governmental organizations, private companies, and governments. His research interests include patient-centered care, assisted dying, the ethics of emerging technologies, and clinical practice. I turn it over to you. Thank you again for being here with us.
Thank you, Michael. Hello, everybody. It's great to see you all. I'm going to just a couple things to mention before I get going. One of them is that if you're interested in looking at these slides or you want to follow along, they're on my website, ericmatheson.ca. You can click under research, or you can use your phone to scan that QR code, and that will pull it up there. So I'll just give you all 10 more seconds in case you want to do that. And then the second thing I want to do is give a plug for my own workshop, the Toronto Bioethics Workshop, which is now in its third year. It's coming up this June in Toronto at the University of Toronto. The most pressing thing to mention to you, though, is that if you're interested in presenting at this workshop, the deadline for that is March 31st. So you can click on that link or look it up on Phil Events. We would love to have you out. It's free to attend the workshop. And it's long sessions, an hour and 15 minutes for each person. So it's a really good chance to kind of dig into stuff. But with that, what I want to talk about today is coercion and how it affects clinical decision making. I'm going to start by giving some background so that we can all kind of be situated in the same way around how coercion fits into kind of broader ethical things around informed consent. The first place to start is just to note, to kind of point out this magical property that informed consent has, where it transforms what would otherwise be very wrong actions into actions which are totally permissible. So think about somebody coming up and punching you in the face. That would obviously be something very wrong, kind of absent of other information. But if you and that other person agree to have a boxing match, then it's totally fine. You can punch each other as much as you want, and that's okay. Similarly, if a doctor were to come into your hospital room and put you unconscious and then take out your appendix without your consent, then that would be very wrong. It would also be illegal, a form of battery. But if the doctor comes in and gets informed consent, then that transforms the same act of removing your appendix into something that is totally permissible, nothing untoward, nothing unethical about it at all. There are lots of different views and lots of different discussions about what the necessary and sufficient conditions of informed consent are, but there's broad agreement that they share something like the four following criteria that's necessary for valid consent. So the first one is that the person has to have decision-making capacity. That is, that they have to be capable of actually making a decision in the right sort of way. The second is that they have to be given information necessary to make the decision. So this is the informed part of informed consent. More than that, they have to understand what that information is. So just being given a bunch of legalese or medicalese that they don't actually kind of parse, that doesn't satisfy the criteria, and they actually have to understand it for themselves. And then the final one is that when they make a decision, it has to be voluntary. And this is the one that I'm going to focus on today. I have lots of thoughts about these other three criteria, but I'm just going to set those all aside and just talk about voluntariness. And the most kind of paradigmatic way, if you want to impact voluntariness, is to do it by coercion. So coercion, if you think about the kind of like very standard paradigmatic case of the gunman who comes up to you and says your money or your life, when you hand over your wallet, you're not doing that. I mean, you're making a choice to do that. But the standard story is that it's not valid consent because you've been coerced. You haven't done it in a free way, kind of by your own free volition. So there are other ways of affecting somebody's voluntariness, but coercion is definitely kind of one of the strongest and the one that's received a lot of attention. There is a really large literature that's been going on for many decades about what coercion is. And basically, for the purpose of this talk, I'm not going to say anything about the different views. I'm going to be totally kind of neutral about the different theories of what coercion is and like how we recognize it and so on. I'm instead interested in a different sort of question. And this is a question that's actually received a lot less attention. And I hope to show a surprising lack of attention because I think that it does kind of raise important ethical issues. And the question that I'm interested in is just assume, like, let's just stipulate that we have somebody before us whom we know has been coerced. So we just like define the case in such a way that the person has undoubtedly been coerced in a clinical setting. The question I'm interested in is what should we do with this person? Like, what should happen once we've stipulated that that coercion has occurred? And uh, as I said, that there's been a lot written on what coercion is, and there's been a lot written about for the other criteria for informed consent, what to do when those aren't met. But a lot less has been written on voluntariness. So just to quickly kind of by analogy, think about the frameworks that we have, both legally and ethically, if a person lacks capacity. So we've got decision-making hierarchies, and we've got kind of processes in place to identify substitute decision makers and do the capacity assessments and so on. And all of that is kind of well established. There's disagreements within that, of course, but it's kind of broadly understood what should happen in those situations. But by comparison, there's very little that's been said about what should happen when a person's been coerced. So that's my target for today. I'm going to motivate this issue by describing a case to you, which is based on a real clinical case that I had. And I'm going to call the case the threat. And I'm going to invoke my God-given right as a philosopher to describe this case as thinly as possible to motivate it so that we don't get distracted by specific details of the case. The specific details are quite interesting and rich, but for my purposes, I want to just kind of outline what I think are the morally relevant factors, and then feel free to ask any questions in the Q&A if you think that there's other details that might be relevant. So here's the case. There was a patient in his 50s, and he had a life-threatening condition. And so very sick, he'd been in the ICU for a few days. The doctors, the surgical team, the transplant team, there are lots of different teams involved. They had done the workup, trying to figure out what the best way forward was for this guy. And there was a meeting with the patient and the patient's wife and a bunch of the clinical members and then me. And during that meeting, the kind of head clinician involved, he presented two different options for the patient, basically two paths forward, which, following up on my promise of thinly describing it, we'll just call them A or B. So these two different options. And importantly for our purposes, A and B, from the clinician's point of view, are on a par. What I mean by that is that there are pros and cons. There are quite different kinds of interventions, but clinically speaking, the doctors had no reason to kind of prefer one or the other. So it just depends on what the patient's values are, what he cares about. It's not that one is like much better in terms of life expectancy or recovery time or anything like that. They're just these different trade-offs. So totally on a par. It's up to the patient to decide. During that meeting, the clinician has described, working through, talking about these two different interventions. The patient has asked a couple of questions. And at that point, the patient's wife interjects and she says, "You're going to choose option A. Otherwise, I'm taking the kids and you'll never see us again." And this is basically what happened, kind of verbatim. And so the doctor and I exchanged kind of a look, and we kind of wrapped up the meeting shortly after that, and then had to figure out what the next steps would be. So let me add just a slight bit of context to this. I went and spoke to the wife shortly after, and I said, "Oh, things got kind of heated in there," and she explained to me there was kind of the context or the backstory for why she had this strong response. And it doesn't really matter for our purposes here, but just to kind of note that it's like, I don't think it like justifies the action that she had, but she had kind of she had an explanation for it. The more relevant things for our purposes are that I said to her, so are you serious about this threat, or is this kind of more of a rhetorical strategy? And she said, "Oh, no, I'm completely serious. I'm going to do this, that he has to choose option A." And then shortly after that, I went and spoke to the patient and kind of talked to him for a while. And I said to him, "So do you think she's serious?" And he said, "Oh, yeah, she's completely serious. I can tell." And then the last part to add is that he really didn't want to lose his marriage, didn't want to lose his family. So this was a like an effective threat in the sense that it meaningfully was shaping already, kind of shaping how he was thinking about the decision. It wasn't that he was like, like I don't that doesn't matter to me. It mattered to him a great deal. So to take stock of kind of what the impact of this is, seems to me that this is definitely coercion, that the wife is coercing her husband. The standard story about this is that she's coerced him to a serious degree, so enough that there would be doubts about the patient's ability to make a decision voluntarily. That was the doctor's view when I spoke to her after. And then, it follows from that there's a serious risk that this is threatening his ability to give valid consent. To show that we're kind of setting aside the other three criteria, just to point out that there's nothing wrong with his capacity. He was still capable of deciding. Been given all the information. He understood the different decisions or the different options. So this is purely about the voluntariness of his decision. So the question is, now what do we do? Like us being clinical people, what should the ethicists recommend, and what should the doctors, what are the options that the doctors should be able to pursue? That was the kind of issue that we were facing in this situation. I'm going to give two different arguments for what I think should happen. I'm going to tell you what I think should happen on the next slide here. But the first kind of argument I'm going to give is what I'll call the simple argument, to try to kind of motivate the reasoning behind it. And then I'm going to give a more complex argument to try to uncover maybe a bit more about the like kind of foundational ethical stuff about what's going on here. So first, the simple argument. I think that what should happen in this case is that the patient should still be allowed to decide for himself. That is that he should still be, before the doctors can do any intervention on him, that he still needs to give consent, and I think that consent would be valid. So that's kind of the answer. Allow the patient to make a decision. It's a bit too simple to say, like it's as though the coercion doesn't matter. I don't think that's quite right, but I do think that he should be allowed to decide for himself. And the simple argument is that he should be allowed to decide for himself because all the other options available to us in this situation are worse. So if I can't actually go through every other option available. So I'm going to go through what I take are the three kind of most promising options, and I'm going to explain why those are just not going to work, despite maybe they seem intuitive or promising at first glance. But let me say here, I'm very, very interested to know that if you see another kind of path, another option that I haven't considered, then I would love to hear about it. So the three that I'm going to consider are that there's no treatment, that he's been coerced, so we can't have any treatment, that we should try to remove the coercion and proceeding is only appropriate once the coercion has been removed. And then the last one is kind of more of a Hail Mary option. It's that maybe we should use a substitute decision maker. But as I say, I think that all three of these are ultimately untenable. And so the right thing to do is to let him decide. So basically that the coercion is not making a meaningful difference to the assessment of this case. So first things first, no treatment. Well, the argument in favor of this, and by no treatment, I just mean that we say to him, sorry, you've been coerced, you can't give valid consent, and so we can't proceed here. That would be the kind of outcome, and the argument for it is that he can't give valid consent because he's been coerced, and coercion impacts voluntariness, and voluntariness threatens valid consent. So that's the kind of simple story about it. But whatever else is true, it strikes me that this just cannot be the right way to go. It can't be the right view that he is, he's the victim. Like it can't be that he is made worse off by being coerced in this situation. He's really sick. He's in the ICU. He'll probably die pretty soon if he doesn't have one of the treatments, either A or B. So something needs to happen to him to save his life. And it just seems, completely ethically unacceptable for us to say, sorry, you're out of luck because you were coerced. I believe this so strongly that I made this mock-up of a t-shirt for a slogan that says, if you've been coerced, your care shouldn't get worse. And so I don't actually have this shirt, but that's how strongly I care about it. It goes on a shirt. All right, so that can't be it. He's got to get some treatment, one way or the other. And so then we got to figure out which is the best one for him. So maybe I think maybe the most obvious decision or next move is that we should remove the coercion, and that once we remove the coercion, then that will kind of solve the issue, and then we can figure out what he wants, and then go for it that way. So this is the straightforward thing to do in other cases. So if you were watching for some reason, like watching a gunman threaten somebody else and say your money or your life, and you had the means to intervene, or you could call the police or something, then that would naturally be the right thing to do to try to stop the coercion from happening. So there are certainly other cases where removing the coercion would be the right thing to try. But in this case, unfortunately, it's basically impossible. That, in fact, I tried, in speaking to the wife, I said, wouldn't it be better, or don't you think that there's a case that he should be, just kind of allowed, or like he should kind of make the decision based on his own values without kind of being pressured one way or the other? And she said, no, I think he should have option A. That's the thing that he should have. So she wasn't going to remove the threat. And there wasn't really an option to remove her. Like, after all, the husband still wanted her around, so wanted her to visit. But even if we said you can't come into the hospital anymore, that's not going to remove the threat. She would still know which treatment he ended up getting, and it would still be kind of obvious based on the nature of the treatments which one he had got. So she could still kind of keep up the threat even if we removed her from the hospital. So I don't see that there's like any kind of compelling way that we can remove the threat as such. Based on the kind of nature of the case. So unfortunately, that's not available to us. So the Hail Mary option, I just want to kind of mention this. I'm not sure how compelling this is, but that the Hail Mary option is that we should use a substitute decision maker. And the case for using a substitute decision maker is that, as I mentioned before, in cases where a person has lost decision-making capacity, then the kind of framework that we use, or the kind of like process step, is to give that person a substitute decision maker who then makes decision kind of based on his wishes if known, or based on his best interest. And so maybe what we should do in this case is that, given that there's this like claim that the patient's unable to decide, maybe a substitute decision maker would be appropriate. Now, I think for like at least 3 or 4 strong reasons, this is not going to work. Practically, it'd be very difficult. It can't be his wife. It would have to be somebody else. Does the patient get to decide who's going to be the substitute decision maker? It's not going to work. But the kind of like more troubling ethical component of this would be, suppose that we do assign a substitute decision maker, and that SDM makes a choice, either A or B, then what's going to happen? Like we show up in the hospital room and say like, okay, we're going to give you your treatment, and the patient's like, wait, don't I have a say in this? So it just like seems like pretty clear that that's not going to work. One more kind of even deeper problem is that it reveals this kind of issue about how he's making his decision, even in light of the threat. So it seems to me pretty clear that if somebody were a substitute decision maker for this guy, that the SDM, would also have to take the threat into account. After all, this is like an important thing that he cares about. Like, it's a value to him that his family stays together. And so we're thinking about like, well, what are his values? What does he care about? He cares about keeping his family together. And so then it seems like the SDM is kind of obligated to decide identically to what the patient would have decided anyway. And so that kind of puts us in, there's like kind of a reductio or a dilemma going on here, that in that case, either the SDM is also coerced, in which case we have to find another SDM, but that person's coerced SDMs all the way down, or the SDM is not really deciding any differently to how the patient himself would decide, and so we should just go with the patient. It's just a better way to go. All right, so that's the 3 reasons why can't work to use none of the kind of other options. are promising. As I say, if you can think of something else, please let me know. So the case for letting him decide is that he can still kind of consider his options in light of this threat. The threat is not good. Like it's regrettable that he's been coerced, but we can still, he can still reason about it and say like, okay, now like it's going to reweight his decisions, but he can decide in light of this. So he's still going to kind of get what he wants, even though his like the option set has been significantly constrained. So the summary of the simple argument is that all the other options are worse, and so we should let him decide. And that's a kind of like, argument by exclusion. Now, practically, like this gives us what I think is the correct result, but it's kind of unsatisfying in a couple of different ways. One of the ways it's unsatisfying is that it doesn't really explain why it should be the case that he should be allowed to decide. That is, it doesn't really like interact with the standard theory of informed consent that we have, which says that if voluntariness is removed, then that valid consent is impossible. So we need some kind of deeper explanation that that kind of like communicates or like kind of has something to say about that account. And then the other thing about the simple argument so far is that I'm worried that it kind of makes it sound like it's by accident. There's this kind of like contingent feature of the case, that it just kind of shook out that way. But actually, I think it's actually there's a much deeper thing going on, which is that I think he should still be allowed to consent because I think valid consent is actually still possible for him. And I've changed my mind about this. This is kind of the updated version. In the abstract that was sent out, it kind of had a different story, that was the same result about what should happen, but a different explanation. So now I've kind of changed my mind a little bit. All right, so that leads us to the complex argument. The complex argument goes like this. So to understand a little bit more about this particular case, what's going on in the threat, that it's helpful to notice that there's a structural feature about it, which is makes it distinct from typical cases of coercion that we talk about. So paradigmatically, coercion is dyadic. That is, that it's between two different parties. And the person who is the coercer is also the consent seeker. So think about the gunman case. He says your money or your life. What he should really be doing, if he were going to get valid consent, is he should say, "Hey, can I have some money?" And if the person says no, then it's like, "Okay, well, thanks." But instead, what he's doing is saying, like, hand over your wallet, or I'm going to hurt you. And so he's the same person, the coercer and the consent seeker, sending the threat over to the coercee or the patient. And then that individual is going to kind of send consent back the other way. It's invalid consent because of the threat that's going on here. But the kind of like key detail is that it's bidirectional. One person is doing the coercing and one person is doing the consenting, and it's kind of going in both directions. So at the start, I said that informed consent kind of has this magical property that it transforms actions that would otherwise be very wrong into actions which are totally ethically permissible. But the additional feature about that is that this magical property is this transformation between two specific parties. So if I agree to have a boxing match with you, I'm not agreeing to just like a boxing match with anybody. I'm agreeing to having a boxing match with you. It would be just as wrong as it always would be if anyone else came up and punched me, even though I've given consent to you punching me. Similarly, if I consent to a doctor taking out my appendix, then it would still be just as wrong for some other doctor to come and, I don't know, like remove my spleen or something like that. So it's between two specific parties. And the nature of consent, I think that like kind of what's deeper about valid consent is that it's determined by what those two parties owe each other. That it's not, there's like a right way to go about seeking consent, and there are like things that have to be fulfilled. And the person who's seeking consent, it has obligations about how he or she goes about doing that. And the person who is giving consent kind of has entitlements, if you want, has rights to be treated a certain way. So the voluntariness requirement is violated when the consent seeker wrongs the person. So when the gunman says your money or your life, he's wronging you because he's threatening you. He's like coercing you into handing over your wallet instead of going about it the right way, asking politely, saying please or whatever, instead of threatening you. But it's that wrong that's going on, that's kind of the key violation that's undermining the voluntariness requirement. So you're entitled to the physician not removing your appendix without your consent. If she does remove your appendix anyway without getting consent, then she violates your entitlement. So using that kind of like structure, that language, we can cash it out in those terms that you have an entitlement to be treated without coercion, and the physician who violates that is violating that by wronging you. That's the nature of the wrong. Now, so that's the standard story. Typically, when you think of coercion, it's probably a dyadic case. But the threat is not a dyadic case. The threat is a case of what we can call third-party coercion. And so just to walk through how this is different, in the threat, the coercer, the wife, is threatening her husband. And so they have this relationship where the coercer is threatening the patient. But the person who's seeking consent, the clinician, is a different person than the coercer. So the clinician is seeking consent. The patient's going to send consent over here. But the clinician doesn't have anything to do with the threat. The clinician isn't the one doing the coercing. That's a different person. So you can think of these as two separate relationships. In the dyadic case, it's bidirectional. So it's two people kind of going back and forth. In the third party case, it's not bidirectional. The coercer is threatening the patient, and the patient is sending consent over to the clinician, who's a different person. In this case, this relationship over here and this relationship over here. And this, I think, is a key detail to understanding or motivating the view that I want to get to. So in the threat, the patient has no entitlement against the clinician that his wife not threaten him. That is, to say that less jargony, that the patient has a right not to be coerced. He's being coerced by his wife, but he doesn't have a right against doesn't have an entitlement against the clinician to ensure that he isn't being coerced at all. That's a strong way of putting it. Kind of softer way of putting it, which I think still gets us to the same result, is that the patient's consent isn't contingent on the clinician removing the threat. So maybe it's the case, and I'm going to say a little bit about this right away, that the clinician should do something to try to remove the threat. But whether or not the threat is removed, that isn't the validity of the consent does not turn on that coercion being totally removed or not. So the clinician is the one seeking the consent, and he or she can get that consent regardless of whether there's kind of some other coercion going on with a different relationship. But another way, the wife, not the clinician, has wronged the patient. And I'll just stipulate that it's wrong, the coercion in this case. The clinician owes the patient freedom from his or her own coercion, but not freedom from the wife's coercion. So it's a different kind of relationship. And I think that the consent can go forward because the clinician doesn't owe, it's not, the consent isn't contingent on the clinician removing the threat from the patient's wife. So this ties into the kind of the kind of underlying foundation of what informed consent is, that we want to meet this voluntariness condition. But what I think this shows is that voluntariness is not voluntariness writ large. It's voluntariness between the person who's giving the consent and the person who's seeking consent. And so the fact that there's coercion going on at in a different place in this guy's life does not, I think, invalidate his ability to give informed consent to the clinician. That's the That's the story. So, therefore, let the patient decide for himself. It gets us to the same place, but with a more complex story about how we got there. Let me hasten to say that this doesn't mean that the coercion is permissible or that we're not, or I'm not claiming that the wife has done nothing wrong. I think she probably ought not to have threatened him in this way. There are lots of cases where, coercion, sometimes coercion can be permissible, but because he can still validly consent, that's not saying, okay, well, there's no ethical problem here, or there's nothing else for us to do, kind of clinically speaking. The explanation for why the wife has wronged her partner is that she wrongs him by unjustly constraining his options. I think it's unjust. He should be allowed to decide for himself. But I don't think that this affects his ability to give consent. So this is kind of breaking like what we otherwise in dyadic situations, what we see as like a very kind of one-to-one relationship, that kind of neat or like kind of cleaner story that if you've been coerced, then that undermines valid consent. But in this case, he could still be coerced, but his ability to give consent is not affected. So it doesn't mean that it makes no difference. Both, I think, like in a sense, like it doesn't make a difference, kind of ethically about what ought to happen in terms of whether he can give consent. But it still makes a difference in terms of practically what ought to happen in the kind of clinical setting. So there are still, lots of things that I think that should be considered. The first one, which I'll say more about as well, is that I think that in many of these cases, trying to remove the coercion is an ethical obligation of the team involved. So the kind of like easiest way to solve these cases would be to remove the coercion. And so if you can do that, then that's where you should start. But that's not always going to be possible. Other sorts of things that you should document the coercion. The patient himself, he might need other sorts of support. So you should involve social work or clinical ethics or legal or whatever is kind of appropriate for the situation. So it's not the case, or I'm not claiming that the coercion makes no difference or that we can just ignore it. There's still lots of stuff that follows from it, but I just don't think that that extends to that means he can't give consent. So that's the kind of two arguments. Let me give you a couple cases to show you how I think that this applies. Um, so the first case you can imagine a kind of a serious case where a person comes in to the emergency department, say, in an abusive relationship, and she seeks long-acting contraception to protect herself from her partner's behavior. So this is a serious case. The first step in this case, she's clearly being coerced. And I think that the first appropriate step would be to try to remove the coercion. So you could, offer her, maybe she can go to a shelter, or maybe there's some, involve social work. Maybe the police should be involved. Like, kind of figure out like what the, what would be appropriate in the kind of more detailed circumstances, and try to remove the coercion. But suppose that you offer all those things, and she says, "Thank you. I appreciate all of this, but that's not going to work for me. I would just like to have the contraception." So the second step then is that like as with the threat, if the coercion can't be removed, would it be ethical for the physician to deny her care? That is to say, well, I'm sorry you've been coerced, so you can't give valid consent in this case. And I want to say emphatically, no. It would not be ethical to deny her care because you shouldn't be made worse off just because you've been coerced. So I think that she should still be given the contraception. And I think that that's the case, and she can still give valid consent. So it's not like a best interest story as such. It's that she's still able to give consent. Here's a more, another extreme case. Suppose that the mob threatens to hurt a patient's family unless he gives his kidney to the ailing mob boss. So, like a very serious coercive case. Once again, step one is try to remove the coercion. Honestly, I don't know, like what the steps would be. Call the police. Maybe there's like witness protection or something like that that would be appropriate in this case. But if it turned out for some reason that the coercion can't be removed should the physician do the transplant? In this case, I think the answer is no. But I it's not because the guy is unable to give valid consent. I think it's probably for some other story that it violates non-maleficence, or it sets a bad precedent that the mob will just keep threatening people like this, or it's outside of like the physician's duties. So there are different reasons that we can give, but I think that whether or not he should get the he should whether or not the healthcare provider should do the transplant is not contingent on, it's not making a claim about the patient's ability to give consent in this case. I think rather it's about something else. This accords with my intuitions about what should happen. And so it's not generating what I think are terribly implausible conclusions. Okay, so to kind of start to wrap up here. So my story so far has been that in cases of third-party coercion, the individuals who are being coerced are still able to give valid consent because the simple argument says that all the other options are worse. So in the case where all the other options are worse, then the patient can still give consent. And the complex argument is that the patient should still be allowed to give consent because valid consent is still possible for him. That valid consent is about the relationship between the consent seeker, the clinician, and the patient himself. And so there might be coercion going on in some other kind of relationship, and that's important for practically what we should do, but it doesn't actually invalidate the consent, the ability of the patient to consent between those two people. So I just want to close by saying that it might seem like a kind of like unusual or rare case, the one that I described. But once you notice the structure of third-party consent, or sorry, third-party coercion, that it turns out that I think that third-party coercion is actually very common in healthcare. In fact, it might be the most common form. So I just want to give you a few cases to show how it might appear in other situations. So this is very similar to a consult that I had during the pandemic. A tenant in her 20s receives notice from her landlord stating that her lease will not be renewed unless she provides proof of COVID-19 vaccination within 2 weeks. She does not want the vaccine, but cannot afford to move. She presents to a vaccination clinic and consents to the vaccine. So in this case, she's being coerced by her landlord, who's threatening to evict her. And I think that she can still give valid consent in that case. Again, not to say that the coercion can't be removed, but if it can't be, she can still give valid consent. Another case, a man in his 40s with a history of psychosis is charged with a nonviolent offense. As a condition of a community supervision order, the court requires him to attend psychiatric appointments and accept antipsychotic medication. He has capacity and does not want the medication, but he prefers it to incarceration. His psychiatrist seeks his consent at each appointment. So once again, the threat is coming from the court order, the threat of imprisonment or some other kind of punishment, but the consent relationship is between the psychiatrist and the patient. And for those of you who had Eric talks about MAID on their bingo cards, I don't want to leave you hanging, so here's a MAID example. An eligible patient in her 60s with a terminal diagnosis has submitted a MAID request and completed her first assessment. Her adult son, who is her primary caregiver, tells her that if she proceeds, he will have nothing more to do with her and will not help her, not help care for her in her remaining weeks. So in each of these cases, my claim is that the patient can still weigh the options available, including the threat, like with the threat kind of built in, and decide for him or herself. And the voluntariness requirement isn't threatened because consent isn't contingent on the coercion being removed. Or that, at least I want to say that in every case, it's not contingent. There might be cases where it's very easy to remove the coercion or some other thing, in which case maybe there is something more like contingency, but there are certainly many of these cases where that's not true. And then finally, that the coercion is still wrong. So it's not like, this doesn't matter, like go ahead and coerce people. Absolutely not. It's still wrong to coerce people, but I just think that there are these cases where it doesn't invalidate consent. And then, so finally, to close this off, I just want to kind of notice whether or not you think that this is a good result or a bad result, I didn't kind of set out to to come up with this result, but a feature of it is that if it's correct, then it means that it's kind of taking a different approach from a lot of the consent talk over the last decade or two. So it's been kind of this story in bioethics of these kind of like consent getting more and more restricted. That are all these factors kind of going on in the world, all these ways that our voluntariness can be affected, structural factors and relationships and so on. And this account that I'm offering here is actually goes the other way, that it's more expansionist, that shows that even when there are these coercive factors, that consent can still be preserved. So thank you very much. I look forward to hearing your questions.